Hi, welcome to Case of the Day, and we're on our 22nd case. And like I said, I'm constantly surprised. We've made it so far, but it's the sixth week, and here we are. Today it's rheumatic mitral valve disease and CMR. And I reported this patient today. We scanned the patient yesterday. 25-year-old with breathlessness, and echo showed rheumatic mitral valve disease and a little bit of aortic disease as well. And you can clearly see the MS, the MR, and the abnormal mitral valves, but that's better appreciated on the static images. We see the hockey stick appearance of the anterior mitral valve leaflet, the thickening, and perhaps calcification and the dilatation of the left atrium. The short axis shows this classic fish mouth appearance of the mitral valve with areas of thickening and probable calcification. That's the three chamber, which again shows everything so well. You've got the MS, the MR, the AR, and the AS, but we didn't do this to quantify the aortic part of the abnormality, and you can also see the abnormality of the anterior mitral valve leaflet. So we did planimetry in as part of the reporting. So the mitral valve area is 93 square millimeters. Mitral regurgitation was probably underestimated. This is the LA size, and AS and AR were not quantified. I talked about this, I think, a couple of months ago at mricardiac.com, and you'll see the link to that on the top right. Like I said, I'm still learning this part, but I think there should be a link there that will take you to the video. And I've got a longer video that explains how to diagnose these on MR and why it is so important. So, to summarize, rheumatic heart disease, especially mitral valve disease, can be evaluated with CMR. And Indian radiologists working in CMR should be more cognizant and aware of these findings because subclinical RHD is quite uncommon. So, this was a patient I saw day before, reported yesterday, rather scanned 3-4 days ago and reported yesterday. And you can see the patient came for viability imaging. It's basically hibernating myocardium in the LAD territory. But look at this hockey stick appearance, and this is subclinical RHD. This is abnormality of the anterior mitral valve leaflet with a hockey stick appearance, and nobody had picked it up so far, and we can. So if we can, we should read it. Perhaps in this patient at this age it makes no difference, but if you can do this with younger patients, perhaps it will make a difference. Remember, it's a significant public health burden in India. Disease of the poor, with greater than 100,000 deaths per year across the world. 3.5 out of every 1,000 kids is the prevalence in the 5 to 15 years age group, and 7.6 per thousand in all age groups, again across the world. It's the commonest cardiac disease in India, except ischemic heart disease and hypertensive heart disease, and yet we know so much about IHD and HHD in even in India, but we know so little about rheumatic heart disease and MRI, and it is the commonest cause of valvular heart disease. And so, remember, even planimetry is as good as echo, and perhaps in the future we'll know more about why CMR would be useful in such patients. But irrespective, I think we should at least know what the mitral valve looks like in rheumatic heart disease with cardiac MR, if nothing else. And then maybe over the next few years, some bright young radiologists and cardiologists will tell us why we should, or which are the specific indications where MR really helps in such patients. That's my WhatsApp channel, and thank you so much for listening to this.